I'm Dr. Jerry Hesch, a physical therapist from the Hesch Institute in Aurora, Colorado. And my client has been kind enough to let me film the spring testing that I do to evaluate upper cervical mobility. And the lower lumbar spine is the site of the greatest amount of anomalous development, altering shapes of the joint, of the facet joint side to side. And the second most common location is at the occipito-atlantal joint. And I typically evaluate rotation by placing my thumbs on the mastoid, on the front of the mastoid process, and I'm springing on the left side, which induces left rotation. And now I'm springing on the right, and I feel a little bit of resistance, which I will call a stutter. And so I'm going to go on and test side bending. So I come under the mastoid on each side, and I'm lifting up on the left, and I easily, with very little effort, induce right side bending. And the same thing on the right. I lift up with my index finger, and I induce left side bending. What I'm going to do now is do an oblique spring on the mastoid towards her shoulder at about a 45-degree angle. So to the left 45 and downward to the left. And my thumb is on each mastoid process, and you can see there's free mobility. I have never encountered a resistance in an oblique direction on the left side of the body. And now I'm going to attempt, and I did this previously and I wasn't able to, I'm trying to induce, and I'm putting a fair amount of force. Do you feel like that's more force than I did on the left?
Yes.
Yeah, I'm definitely adding more force, but not getting that oblique movement. And so I describe this upper cervical restriction as though a bird flew up and over your shoulder to the right, and you turned your head to the right and up to look at that bird, and then the occiput stayed there. Now it's a much smaller range of motion than that, but that's the way that I describe the fixation at the occipito-atlantal joint. Treatment is very simple. I apply traction to the upper cervical with a palmar contact on the zygoma and on the temporal bone, and I do straight traction, and then I do a little scoop upward, downward to the left. I don't think you can see that direction, but I'm scooping occiput while it is in traction bilaterally down and to the left. So just think of her chin as being scooped downward and to the left. And so I'm going to do 30 oscillations. And there's 10. And I doubt that the camera can pick up these subtle little gentle oscillations, but I've isolated the force. And for one person, he had headaches for 60 years. And I treated him once, and we're at more than 5 years right now, and he's not had any return of his headaches. He struck his head against a sandbar diving, and apparently the water wasn't as deep as it had been in the past, and he had struck his head. He was 21, and he was 81 when I treated him. And I followed up with his son. We're always in contact, and he's doing fine. So sometimes this oblique pattern can be very significant. And so now I'm on the front of the mastoid, and I'm doing an oblique spring, and I think the camera can easily see that you now have spring mobility. And so what I'll do is I'll turn the camera. We wanted to preserve your identity. And so I'll turn the camera away and have you sit up and move your neck around and tell us how you feel.
Move your face away from it?
Yeah.
Feels looser.
Okay. I'll take that. I'll take looser any day of the week.
Yeah.
Especially my poor neck.
Looser's good.
Very good. Well, thanks for letting me film it. It occurs somewhat frequently in my patient population. Let me suggest that if I had 10 people who had a upper cervical restriction, that at least 2 of them would have it in an oblique direction. And I thank you for letting me film it.